Hi everyone, welcome to AJNR Trainee Corner. In this presentation, we're going to cover the radiological features of common etiologies of ischemic strokes in young adults. I have no disclosures. Compared with older patients, young individuals more often have ischemic stroke secondary to cardioembolism, extracranial artery dissection, reversible cerebral vasoconstriction syndrome, aka RCVS, monogenic disorders, illicit and recreational drug use, hypercoagulable disorders, and pregnancy. The neuroimaging features are not only diagnostic in ischemic infarction, but also provide important clues in determining the underlying etiologies, which can be classified into 5 categories: cardioembolism, which is the most common subtype, large vessel vasculopathy, small vessel vasculopathy, toxic metabolic, and hypercoagulable disorders. Cardioembolic stroke accounts for 15 to 47% of ischemic strokes in young adults and typically demonstrates multifocal small infarcts in multiple arterial territories from showering of emboli. However, a single arterial territorial infarct can also occur because of a single vessel occlusion from a solitary embolus. In addition to blunt emboli, atrial myxoma, septic emboli, fat emboli, and air emboli are also culprits we can help identify on imaging. The first case shows a cardioembolic stroke from atrial myxoma. Multifocal embolic small acute to subacute infarctions involving the cerebellum and anterior right frontal lobe, demonstrated on DWI images A and B. Because the emboli are from surface thrombus surrounding the atrial myxoma or from tumor fragmentation, they can also lead to rare complications such as aneurysm formation and metastasis. Myxomatous intracranial aneurysms are surely multiple and have a predilection for distal branches of MCA, like in post-contrast images C and D, and confirmed on cerebral angiogram of image E. They are surely hyperdense on HCT due to the accumulation of myxoid matrix or calcification in the aneurysmal wall. Cerebral myxomatous metastases are typically multiple and hemorrhagic and are most common in the frontoparietal region. Like in this case, there are multifocal enhancing hemorrhagic lesions involving bilateral frontal and left occipital lobes with marked surrounding edema. The second case shows septic embolic infarctions in a patient with Streptococcus sanguinis bacteremia, pacemaker endocarditis, and periaortic graft infection. DWI images A and B show multifocal supratentorial acute to subacute infarctions. A dominant lesion in the left occipital lobe is present and has associated hemorrhage as seen on SWI image D. The internal punctate focus of enhancement, white arrow on image E, raises a suspicion of a mycotic aneurysm, which confirmed on the cerebral angiogram of image F. To diagnose septic embolism on imaging, the clinical history is important as multifocal small hemorrhagic metastases can have similar patterns. You may wonder if DWI can be of help in differentiating those two, as infarctions and metastases are fundamentally different etiologies. However, in cases of septic embolism, the infarctions are most likely associated with hemorrhage, which will obscure the DWI hyperintensity. On the other hand, the small multifocal metastases may demonstrate increased DWI signals. In those situations, clinical history would help a lot. The third case shows fat embolic infarctions in a 22-year patient with a left open tibial fibular fracture. There is a star-filled pattern of punctate acute to subacute infarctions scattered throughout the cerebrum and cerebellum, with the involvement of deep gray nuclei and splenium of corpus callosum. The SWI shows innumerable punctate foci of susceptibility effect in the same regions, representing microhemorrhages. A right to left cardiac shunt is not a precondition since the marrow fat droplets can deform and travel through pulmonary capillaries. The clinical history is important as it is classically seen in patients with lung bone fractures or pelvic trauma with a classical triad of acute respiratory failure, skin petechia, and ischemic stroke. Air embolism is rare but can occur during invasive procedures and may involve arteries or veins, as shown in the two cases here. In the left-sided case, the patient had left-sided hemiplasia and gaze deviation to the right after esophageal dilatation. There are parenchymal punctate foci of air in the right ACA/MC watershed distribution, consistent with the arterial pattern. The venous pattern on the right side appears as serpiginous air in cortical veins with adjacent gyroform venous infarctions. This patient had respiratory distress and loss of consciousness following a prolonged surgery for a right lower limb gunshot wound. There is evidence of serpiginous air densities in the south side of the frontal and parietal lobes. A follow-up HET CT was performed after 24 hours. There is interval development of hypodensities in both cortical and subcortical regions consistent with venous infarctions. Large vessel vasculopathy comprises early atherosclerosis, cervical artery dissection, radiation-induced arteriopathy, Takayasu arteritis, fibromuscular dysplasia, crowded web, and vascular Ehlers-Danlos syndrome. Case 5 shows a cervical artery dissection in a trauma patient with displaced stance fracture resulting in severe canal stenosis. Multi-compartmental intracranial hemorrhage is present, including right anterior frontal hemorrhagic contusion and subrectal hemorrhage within the right Sylvian fissure and bilateral frontal parietal south side. Foci of hemorrhage at the right splenium of corpus callosum is suggestive of traumatic axonal injury, which can be seen on the SLY image of image D. CT angiogram E and F shows distal right cervical ICE dissection with pseudoaneurysm. In another patient, right petrous ICA dissection shows narrowing of the true lumen and adjacent intramural hematoma on image G and F and H. Intracranial dissection is rarer compared to the cervical dissection. In a patient with recurrent infarction within the posterior circulation, previous brain and neck MRA, not shown here, repeated a few times, were all normal. CTA was performed and there is a linear filling defect within the basilar artery, as seen on image D, E, and F, suggestive of intracranial dissection. In the management of head and neck cancer, carotid arteries receive significant doses of radiation. Radiation can result in morphological features like those seen in spontaneous atherosclerosis. Differentiating factors are accelerated progression, a longer segment of involvement, and a higher incidence of complications after carotid enterectomy and stenting. K7 shows progressive atherosclerotic changes on image C and D, involving left carotid artery compared to 1 year ago on image A and B. In a patient 5 years post-radiation therapy for tonsil squamous cell carcinoma. Compared to the initial images A and B, the distal left CCA has worsened narrowing, and there are more prominent calcified plaques in the proximal left ICA. CT chest in a patient with Takayasu arthritis shows circumferential wall thickening and enhancement of the aorta and great vessels during active inflammation, as seen on image A, B, and C. On image D, which is an MRA of the chest, shows aneurysmal dilatation of the ascending aorta as a sequela of arterial inflammation without prominent wall thickening or enhancement. Next CT in a patient with fibromuscular dysplasia shows the characteristic string of beads appearance in the distal portions of the internal carotid arteries bilaterally. A carotid web is a thin, linear membrane that extends from the posterior aspect of the internal carotid artery and extends into the lumen, shown on image G and H. On axial view, the carotid web may appear like dissection. Carotid webs are associated with a higher incidence of cryptogenic stroke, especially in the ipsilateral anterior circulation. Vascular Ehlers-Danlos syndrome is an autosomal dominant disorder characterized by the fragility of medium and large arteries due to type 3 procollagen deficiency. Most neurovascular disease reports include intracranial aneurysms, typically developing in the cavernous ICA or along the carotid siphon, subarachnoid hemorrhage, cervical or intracoronal arterial dissection, cervical vertebral and carotid artery ectasias, and carotid cavernous fistula. Although uncommon, vascular EDS is a potential cause of stroke in young people and should be suspected in young patients presenting with unusual or extensive vascular findings. Case 9 shows a 25-year-old male patient presented to the emergency department with intraperitoneal hemorrhage. A 5 mm aneurysm of the splenic artery close to the hilum was found to be the source of the hemorrhage, as indicated by the black arrow on image A. Another area of fusiform dilatation was also noted in the more proximal portion of the splenic artery, noted by the white arrow on image A. On a renal arteriogram, a left renal artery focal outpouching, noted by the white arrow, was present with distal filling defect and infarct of the upper pole of the kidney, suggestive of renal artery dissection. The patient was diagnosed with vascular EDS. Subsequent surveillance head and neck CT angiogram C and D demonstrate a pseudoaneurysm in the distal cervical right internal carotid artery and fusiform dilatation on the other side. In summary, we'll introduce the 5 categories of etiologies of ischemic infarction in young adults: cardioembolism, large vessel vasculopathy, small vessel vasculopathy, toxic metabolic, and hypercoagulable disorders. We went through examples of cases in the cardioembolic category, which is the most common in young adults. In the second category, large vessel vasculopathy, it is most common to have cervical artery dissection and intracranial dissection, radiation-induced arteriopathy, Takayasu's arthritis, fibromuscular dysplasia, carotid web, vascular Ehlers-Danlos syndrome are also good underlying etiologies to consider. Keep in mind, when we encounter an acute ischemic stroke case in young adults, neuroimaging are not only diagnostic but also provide important clues in determining underlying etiologies.